Hello everybody. Today's topic is treatment of multi-drug resistance organism. So here we have a case who is a 68-year-old male patient who underwent laparotomy 3 years back. History of spinal surgery in 2003. History of cholecystectomy in 2014. ERCP with CPD stenting 2023. Now diagnosed with the periampullary CA. He underwent Whipple surgery on 9th of November in 2023. So this patient was in ICU for immediately post-op. Then we have shifted him to the wards. And again, he was shifted to ICU in view of tachycardia, breathing difficulty, altered mental status. So on arrival in ICU, his pulse rate was 103, blood pressure he was maintaining without support, that was 114/70. Respiratory rate was 20, SpO2 was 100. Then on examination, his S1 S2 was hurt. Respiratory air entry was reduced on the right side. Her abdomen was soft, and the CNS GCS score was E4 V2 M5. So we have taken chest X-ray because patient was complaining of breathing difficulty, and we have found gas under diaphragm. Immediately we have taken patient for CT abdomen, which showed perforation. Hence, the next day patient was taken for laparotomy. We have sent his blood cultures to rule out infection, and it showed Klebsiella pneumoniae, which was resistant to the meropenem, and it came into the category of the CRE. Next patient, we have 46-year-old female patient diagnosed with the sickle cell disease. She developed a fever, rash during blood transfusion reaction outside the hospital. And on investigation, LFT came out to be deranged, hence referred to Apollo Hospital for further care. Patient was in vaso-occlusive crisis, so she developed acute kidney injury, obstructive jaundice, had one episode of seizure. CT brain showed SDH. And when we have shifted this patient to ward, she was spiking continuous fever. So we have sent all cultures, and her urine culture shows enterophysin, which was vancomycin resistant. So we labeled her as vancomycin resistant infection, and we have started her on daptomycin. So we'll see what exactly these multi-organ resistant organisms are. So MDR is defined as acquired non-susceptibility to at least one agent in 3 or more antimicrobial categories. So what is XDR? That is extensive drug resistance. That is non-susceptibility to at least one agent in all, but 2 or fewer antimicrobial categories. That is, bacteria will remain susceptible only to 1 or 2 antimicrobial categories. And pan-drug resistance is defined as non-susceptibility to all agent in all antimicrobial categories. So we are encountering different multi-drug resistant organism, and we are going to discuss in this class how to treat, how to deal with this all organisms. So today we are going to discuss about extended spectrum beta lactamase producing enterobacters, that is ESBL, then AMC enterobacters, then carbapenem resistance enterobacters, Pseudomonas aeruginosa with difficult to treat, carbapenem resistant Acinetobacter baumannii, Stenotrophomonas maltophilia, MRSA, and VRE. So first one is ESBL. So what is ESBL? ESBLs are the enzyme that inactivate most penicillin, cephalosporin, and astrona. So we are referring all the ESBL producing organism as ESBL-E here, which includes Entero E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis. So ESBL-E generally remains susceptible to carbapenem. ESBLs do not inactivate non-beta-lactam agent, that is ciprofloxacin, trimethoprim sulfamethoxazole, and gentamicin. So any gram-negative organism has potential to harbor ESBL gene. However, they are more prevalent in E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis. So CTXM enzyme, particularly CTXM15, is the most common ESBLs. Now, most of the lab do not diagnose ESBL. So, non-susceptibility to ceftriaxone, that is ceftriaxone minimum inhibitory concentration, if it is more than or equal to 2 microgram per ml, then it is used as a proxy marker for ESBL production. Now, if we are encountering uncomplicated cystitis and organism came out to be ESBL-E, then how are we supposed to treat it? So we can start with nitrofurantoin and trimethoprim sulfamethoxazole because these are the preferred treatment option for uncomplicated cystitis caused by ESBL-E. And the alternative agent that we can use is ciprofloxacin, levofloxacin, and carbapenem. But if we should always remember that preferred treatment is nitrofurantoin and trimethoprim sulfamethoxazole over this ciprofloxacin, levofloxacin, and carbapenem. Single dose aminoglycoside and oral fosfomycin are also alternative treatment for uncomplicated cystitis caused by ESBL-E. Now, if we are dealing with the case of pyelonephritis and a complicated UTI caused by ESBL-E, then we can use trimethoprim, ciprofloxacin, and levofloxacin as a preferred treatment option for pyelonephritis and complicated UTI caused by ESBL-E. And ertapenem, meropenem, and imipenem silastine, a preferred agent when resistance and toxicity preclude the use of trimethoprim sulfamethoxazole and fluoroquinolones. Aminoglycoside for full treatment course as an alternative option for treatment of ESBL, pyelonephritis, and complicated UTI. Now, what are the preferred antibiotics for the treatment of infection outside urinary tract caused by ESBL-E? So, in that case, we can use meropenem, imipenem silastine, and ertapenem. If a patient is critically ill and experiencing hypoalbuminemia, then meropenem, imipenem silastine is the preferred carbapenem. For after appropriate clinical response is achieved, then we can shift to the oral trimethoprim sulfamethoxazole, ciprofloxacin, and levofloxacin. So, is there any role for piperacillin tazobactam for the infection caused by ESBL-E? The panel suggests trimethoprim, sulfamethoxazole, ciprofloxacin, levofloxacin, and carbapenem rather than piperacillin tazobactam for the treatment of ESBL-E, pyelonephritis, and complicated UTI. So, piperacillin tazobactam is not suggested for the treatment of infections outside UTI caused by ESBL-E, even if susceptibility to piperacillin tazobactam is demonstrated. Now, the other recommendations are the panel suggests avoid cefepime for treatment of pyelonephritis and UTI. Cefepime is also not suggested for treatment of infection outside of UTI caused by ESBL-E, even if susceptibility to cefepime is demonstrated. Cefamycin is not suggested for the treatment of ESBL-E infection. The panel suggests against the use of ceftolazone and tazobactam for the treatment of ESBL-E infection, with the possible exception of polymicrobial infection. Now, the MC producing enterobacters. MC beta lactamase are the beta lactamase enzyme that are produced at basal level by number of enterobacters and the glucose non-fermenting gram-negative organism. Their primary function is to assist with the cell cycle recycling. MC beta lactamase are capable of hydrolyzing number of beta lactam agent. So increased MC production resulting from inducible MC expression can occur in the presence of specific antibiotics. It results in sufficient enzymes in periplasmic space to increase MIC to certain antibiotic, most notably ceftriaxone, cefotaxime, and ceftazidime. So Enterobacter cloacae complex, Klebsiella aerogenes, Citrobacter frundi are most common enterobacters at moderate to high risk for clinically significant MC production. Beta-lactam antibiotics fall within the spectrum of potential for inducing MC genes. Aminopenicillin, that is amoxicillin ampicillin, narrow spectrum, that is first generation cephalosporin, cefamycin, are potent MC inducers. Now, what is the role of cefepime for the treatment of infection in case of MC infection? So, cefepime is suggested for the treatment of infection caused by organism at moderate to high risk of significant MC production. For example, Enterobacter cloacae infection, then Klebsiella aerogenes, and then C. frundi, Citrobacteria frundi. Now, carbapenem may be preferred for infection caused by these organisms when cefepime MIC is more than or equal to 4 microgram per ml. Now, is there any role of ceftriaxone? So, ceftriaxone is not suggested for the treatment of invasive infection caused by organism at moderate to high risk of clinically significant MC production. Ceftriaxone is reasonable for uncomplicated cystitis caused by these organisms. Now, is there any role of piperacillin tazobactam? So, piperacillin tazobactam is also not suggested for treatment of serious infection caused by enterobacterus with inducible MC production. Now, what is the role of beta-beta-lactamase production in case of MC? So, panel suggests the ceftazidime, avibactam, meropenem, vorobactam, imipenem, cilastin, relebactam, and cefiderocol is the preferentially reserved for treating infection caused by these organisms who are exhibiting carbapenem resistance. But panel do not suggest the use of ceftolozane tazobactam as a treatment for MC infection. Now, what is the role of non-beta-lactam therapy for the infection caused by Enterobacterus? So, nitrofurantoin, trimethoprim, sulfamethoxazole is the preferred option for the uncomplicated MCE cystitis. Aminoglycoside is an alternative option for uncomplicated cystitis, pyelonephritis, and complicated UTI. Trimethoprim, sulfamethoxazole, and fluoroquinolone can be considered for invasive infection. Now, the next category of the MDR organism is carbapenem resistant enterobacterus. Now, which produces the carbapenemase. So, carbapenemase is divided into the two types, serine beta lactamase and the metallo-beta lactamase. Serine beta lactamase, it includes class A, class C, class D. Class A includes KPC, IMI, SEE. Class C includes MC, ACT, CMY, and class D includes all OXA group. Metallo-beta-lactamase include class B, that is NDM, VIM, and IM. So it is the preferred treatment option when the enterobacterus are susceptible to meropenem, imipenem, but not to ertapenem. So in that case, we can use extended infusion of meropenem. So, if we are dealing with the case of uncomplicated cystitis caused by CRE, then what are the preferred antibiotics? So, the preferred antibiotics are nitrofurantoin, trimethoprim sulfamethoxazole, ciprofloxacin, and levofloxacin. A single dose of aminoglycoside, oral fosfomycin, colistin, ceftazidime, avibactam, then meropenem, vorobactam, imipenem, cilastin, relebactam, cefiderocol. It used as alternative treatment. Notice the preferred antibiotic for treatment of pyelonephritis and complicated UTI caused by CRE. Trimethoprim, sulfamethoxazole, ciprofloxacin, levofloxacin is the preferred antibiotic for pyelonephritis and complicated UTI caused by CRE. Ceftazidime, avibactam, meropenem, vorobactam, imipenem, cilastin, relebactam, and cefiderocol is the preferred treatment option for pyelonephritis and complicated UTI. Aminoglycoside are alternative option. What are the treatment option for the infection outside of urinary tract caused by CRE? When carbapenemase testing results are either not available or negative. So in that case, we can use ceftazidime, avibactam, meropenem, vaborbactam, and imipenem, cilastin, relebactam are the preferred treatment option for the infection outside of urinary tract caused by CRE when carbapenemase testing results are either not available or negative. So for a patient with the CRE infection who within previous 12 months have received medical care in countries with relatively high prevalence of metallo-beta-lactamase producing organism or who have previously had clinical or surveillance culture where metallo-beta-lactamase producing isolate was identified. So in that case, the preferred treatment include combination of ceftazidime, avibactam plus astronam or cefiderocol as monotherapy. So, what is the if our CRE infection has occurred outside the urinary tract and if it is a KPC positive, then what treatment should be used? So, in that case, we can use meropenem, vaborbactam, ceftazidime, avibactam, imipenem, cilastin, relebactam, and cefiderocol as an alternative option. If CRE is NDM positive, then we can use a combination of ceftazidime avibactam with astronam and cefiderocol as monotherapy. If it is OXA48 positive, then ceftazidime avibactam is preferred treatment option, and cefiderocol is an alternative treatment. So, what is there any role of tetracycline derivative for treatment of infection caused by CRE? So, beta-lactam remains preferred treatment option for CRE infection, and tetracycline and eravacycline are the alternative option when beta-lactamases are either not active or unable to tolerate. So, tetracycline derivatives are not suggested for the infection for treatment of CRE, urinary tract, or bloodstream infection. Now, what is the role of polymyxin for the treatment of infection caused by CRE? Polymyxin B and colistin are not suggested for the treatment of infection caused by CRE. Colistin can be considered as an alternative agent for uncomplicated CRE cystitis. What is the role of combination antibiotic therapy for treatment of infection caused by CRE? Combination antibiotic therapy, that is a use of beta-lactam agent in combination with aminoglycoside, fluoroquinolone, tetracycline, or polymyxin, is not suggested for the treatment of infections caused by CRE. Now, the next is Pseudomonas aeruginosa with difficult to treat resistance. Now, there are two terminologies. One is MDR and the other is DTR. So, MDR, Pseudomonas aeruginosa, is defined as Pseudomonas aeruginosa not susceptible to at least one antibiotic in at least 3 antibiotic classes, for which Pseudomonas aeruginosa is susceptible in general. That is penicillin, cephalosporin, fluoroquinolones, aminoglycoside, and carbapenem. So in 2018, the concept of difficult to resistance was proposed, and it is defined as Pseudomonas aeruginosa exhibiting non-susceptibility to all of the following, like piperacillin tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipenem silastine, ciprofloxacin, and levofloxacin. So what if we are dealing with MDR Pseudomonas aeruginosa, then what we should use? And when Pseudomonas aeruginosa isolate is susceptible to both traditional non-carbapenem and beta-lactams, that is piperacillin tazobactam, ceftazidime, cefepime, aztreonam, and carbapenem. Then we can use, then the traditional non-carbapenems are preferred over carbapenem. So for infection caused by Pseudomonas aeruginosa isolate, not susceptible to any carbapenem agent, but susceptible to traditional beta-lactam, then the administration of traditional agent as a high-dose extended infusion therapy is suggested, and we should repeat the antibiotic sensitivity testing. If our patient is critically ill or those with the poor source control with Pseudomonas aeruginosa isolate who are resistant to carbapenem but susceptible to traditional beta-lactams, but then in this case we can use novel beta-lactam agent and that is susceptible. For example, ceftolozane tazobactam, ceftazidime avibactam, imipenem silastine relibactam. So, what is the preferred antibiotic for the treatment of uncomplicated cystitis caused by difficult to treat Pseudomonas aeruginosa? If it is uncomplicated cystitis, then we can use ceftolozane tazobactam, ceftazidime avibactam, imipenem silastine relibactam, and cefiderocol. A single dose of tobramycin amikacin is used as alternative. What is the preferred antibiotic for the treatment of infection which is outside of urinary tract but it is caused by difficult to treat Pseudomonas aeruginosa? So then we can use, in this case scenario, we can use ceftolozane tazobactam, ceftazidime avibactam, imipenem silastine relibactam are the preferred option for the treatment of infection outside the urinary tract caused by difficult to treat Pseudomonas aeruginosa, and in that case we can use cefiderocol as an alternative option. Now, what is the preferred antibiotic if in for the treatment of difficult to treat Pseudomonas aeruginosa that produces MBL? So in that case, we can use cefiderocol. Notice the role of combination antibiotic therapy for treatment of infection caused by difficult to treat Pseudomonas aeruginosa. So the combination antibiotic therapy is not suggested for infection caused by difficult to treat Pseudomonas aeruginosa if susceptibility to ceftolozane, tazobactam, ceftazidime, avibactam, imipenem, cilastin, relibactam, and cefiderocol has been confirmed. Now, is there any role of nebulized antibiotic? So the panel did not suggest the use of nebulized antibiotics for the treatment of respiratory infection caused by difficult to treat Pseudomonas aeruginosa. Now the next organism is carbapenem resistance Acinetobacter baumannii. Now, it poses significant challenges in healthcare setting. So first, this crab is most commonly recovered from respiratory specimen and wounds. Many times we are seeing if we have a chronic patient who is a tracheostomy, and then suddenly that patient is developing fever, he is developing lots of secretion. And if we are sending that culture, then most common organism that we are isolating is Acinetobacter baumannii. So this and if the patient has a prolonged state, then definitely it came out to be CRE only, crab only. So this Acinetobacter baumannii exhibits carbapenem resistance, and it generally has acquired resistant to most other antibiotic, expected to be active against wild type Acinetobacter baumannii, leaving few remaining therapeutic options for us. So the production of oxacarbapenemase mediate resistant to the beta lactase. So in this situation, what are we supposed to do? So we can start with high dose ampicillin sulbactam, total daily dose of 6 to 9 grams sulbactam component in combination with at least one other agent that is suggested for treatment of CRAP. So high dose ampicillin sulbactam is suggested as a component of combination therapy for CRAB, regardless of whether susceptibility has been demonstrated. Polymyxin can be considered in combination, and high dose minocycline and high dose tigecycline can be considered in combination with at least one other agent for treatment of CRAB infection. Then what is the role of cefiderocol therapy for treatment of CRAB? So cefiderocol should be limited to treatment of CRAB infection refractory to the other antibiotic, or in cases where intolerance and resistance to other agent preclude their use. When cefiderocol is used to treat CRAB infection, the panel suggests prescribing agent as a part of combination regimen. So the high dose extended infusion meropenem or imipenem cilastin are not suggested for treatment of CRAB infection. Rifabutin and other rifamycin are not suggested for treatment of CRAB infection, and nebulized antibiotics are not suggested for the treatment of respiratory infection caused by CRAB. Now the next is Stenotrophoma maltophilia. Stenotrophoma maltophilia is a aerobic glucose non-fermenting gram-negative bacillus that is ubiquitous in watery environment. So what is the general approach? So use of two of the following agent, that is trimethoprim sulfamethoxazole, minocycline, tigecycline, cefiderocol or levofloxacin, or combination of ceftazidime, avibactam and aztreonam when significant clinical susceptibility is evident or intolerant to or inactivity to other agent is identified. Trimethoprim sulfamethoxazole as a component of combination therapy, at least until clinical improvement is observed, is preferred therapy for the treatment of Stenotrophoma maltophilia infection. High dose minocycline, that is 200 mg IV or orally every 12 hourly, as a component of combination therapy, that is at least until clinical improvement is observed, is preferred therapy for treatment of Stenotrophoma maltophilia. The panel favors minocycline over tigecycline, although tigecycline is also reasonable treatment option for Stenotrophoma maltophilia infection. Then cefiderocol as a component of combination therapy, it at least until clinical improvement is observed as a preferred therapy for Stenotrophoma maltophilia. Levofloxacin is suggested only as a component of combination therapy for Stenotrophoma maltophilia infection. Then transition to levofloxacin monotherapy for Stenotrophoma maltophilia infection is not advised. The combination of ceftazidime, avibactam, and aztreonam is suggested when critical illness is evident and intolerant or inactivity to the other agent is observed. What is the treatment of vancomycin-resistant enterococcal infection? So we can start with linezolid, that is 600 mg IV or PO every 12 hours is recommended. So the treatment duration is also depend upon the site of infection and clinical response. Then it is very strongly recommended for VRE. The other treatment option is high dose daptomycin, that is 8 to 12 mg per kg per day in combination with beta-lactam, including penicillin, cephalosporin, and carbapenem. It has a weak recommendation and low quality evidence. And the other treatment option is tigecycline, that is 100 mg loading and 50 mg every 12 hourly for intra-abdominal infection, and it has a weak recommendation, very low quality evidence. Now, a single dose of fosfomycin 3 gram PO is recommended for uncomplicated UTI infection due to VRE. Again, it has a weak recommendation. Then we can also use nitrofurantoin 100 mg PO every 6 hourly if we are dealing with uncomplicated urinary tract infection due to VRE. Then also, we can also use high dose ampicillin, amoxicillin, 500 mg per oral or IV every 8 hourly for uncomplicated urinary tract infection due to VR. So we have three drugs for urinary tract infection, which is uncomplicated and caused by VRE. That is single dose fosfomycin, nitrofurantoin, and high dose of ampicillin and amoxicillin. So next is MRSA. So for MRSA, we can use ceftaroline, dalbavancin, daptomycin, delafloxacin, linezolid, and oritavancin and tedizolid are the all possible alternative to the glycopeptide. If we are dealing with the skin soft tissue infection caused by MRSA, then we can use trimethoprim, sulfamethoxazole, or clindamycin for mild, uncomplicated skin infection. If we are dealing this patient on the outpatient basis, then ceftobiprole, ceftaroline, linezolid, vancomycin can be used in case of CAP if it is caused by MRSA. Then the other treatment option is linezolid, ceftabiprole, vancomycin for treatment of hospital-acquired methicillin-resistant pneumonia. Then linezolid and vancomycin are recommended for treatment of VAP caused by MRSA. Daptomycin and vancomycin for treatment of MRSA bacterium. Then trimethoprim sulfamethoxazole as a monotherapy should not be used for severe MRSA infection. So thank you. All this data was based on the Infectious Disease Society of America 2023 guidelines on the treatment of antimicrobial resistant gram-negative infection, then International Journal of Antimicrobial Agents, and then Journal of Microbiology, Immunology, and Infection. Thank you.